and the recording will be posted on the committee's webpage shortly after the meeting. And Pam McEwen, FTAC Liaison to the Universal Healthcare Commission, will now call the meeting to order. Pam?
Thanks, Angela. So welcome, FTAC members. It's now time to start the meeting, and this is going to be our third meeting, so that's exciting. I want to begin with a land acknowledgement today. And last time I talked about Seattle, I thought this would be appropriate to talk about Olympia, where the healthcare authority is located. And we honor and acknowledge the indigenous people who have been stewards of this land from time immemorial, the Stay-Chas Band of the Squaxin Island tribe who still reside in the Olympia area. I'd like to give a warm welcome to everyone who's joining us today. And I'm going to start with an overview of the agenda. You could post it. I'm waiting for it to come up. There it is. Okay, so we're going to begin with a roll call from Angela. And as we are on Zoom all the time, it's hard to get to know each other. So we're going to start having the proverbial icebreaker and beginning today. And the question, so you can be thinking about it, is what's your favorite thing to do in the spring? We're going to be voting on the March 9th meeting summary, and then we're going to have public comment. And then our fellow committee member, Christine Eibner, is going to present and guide us through a discussion on Medicare. We're moving the discussion forward from where we were at our last meeting. We were going to have a vote on those topics and so to give advice back to the Universal Healthcare Commission, and that will be facilitated by Liz Arjan. Then we're going to hear from HMA again about the Commission's April meeting. And then finally, we'll hear from another fellow committee member, Bob Murray, on an introduction to cost containment strategies, which, as we all know, are going to be critical for sustaining a universal health system. I know we have a really packed agenda today. I'm going to work hard to keep us on time so we can get through all these topics. But I want to really especially encourage all the FTAC members to be asking questions and providing feedback as we go through the agenda. I'll turn it back to Angela.
Thanks, Pam. When I call your name, and names are listed on the agenda, by the way, in alphabetical order by first name. And so please remember when your name is called to let us know what your favorite thing to do in spring. And first we'll start with Pam.
Okay, thanks, Angela. So my favorite thing about spring in the Pacific Northwest is how long the light lasts at night. So that's actually my favorite thing to do is I keep watching all the way through to the beginning of summer to see how light it is staying at night.
Lovely. Thanks, Pam. Christine?
Sure, I'm here. My favorite thing to do in spring is to go bird watching with my kids.
Sweet. Thanks, Christine. David?
Good afternoon, everybody. My favorite thing to do is dust my kayak off and get back out in the water and take a fishing pole with me. Go.
Nice. Thank you, David. Eddie?
Hi, my favorite thing to do is also dust off the tennis racket and watch the clay court season over in France.
A lot of dusting. Thank you, Eddie. Next, Esther? Esther? Okay, Ian?
Yeah, my favorite thing is, weather permitting, going out and playing golf.
Very nice. Thank you, Ian. Kai? Kai?
Hey, everyone. Yeah, my favorite thing to do is take a walk around the nice arboretum that we have here in our area with the nice, all the trees and flowers in bloom.
Beautiful. Thank you, Kai. Bob?
Hi, my favorite thing to do is put in a vegetable garden every year. And then this year, I'm supplementing that by putting in a bunch of wildflowers in my backyard, primarily California golden poppy, which is the state flower.
Lovely. Thank you, Robert. And finally, Roger.
Good afternoon, members. One of my favorite things is I'm a bit of a bike rider. So one of the nice things this time of the year is to be able to take off my rain fenders and the gloves I use to do climbing and put on my regular riding gloves and enjoy the outdoors on my bike.
Thank you, Roger. That's everyone. I will turn it back over to you, Pam.
It's hard to hear about all those spring activities. And so we're on the second tab of your meeting packet, which is the approval of the meeting summary. And there's a recording of the last meetings posted on the webpage. There were some changes that were submitted. Angela, I'm going to ask if you could review those.
Yeah, sure. Committee member David DiGiuseppe sent these over this morning for some clarity on the meeting summary. David, is there anything you'd like to speak to regarding your revisions?
I'd just like to say that I reviewed at least my portions and felt like this was a better representation of the meaning of what I thought I had conveyed at the time. And if anybody disagrees or would like some clarity, I'd be happy to respond to that.
Excellent. Thank you, David. Any members need any clarity on David's edits? Okay, Pam, back to you. I think we can continue.
Okay, are there any other further changes or any discussion of changes? Okay, I'm hearing none. I propose that the minutes be accepted with David's changes. Any further discussion? All those in favor, please say aye.
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 Any opposed? Okay, I believe the minutes are approved by consensus. Thank you. Next, we'll move on to public comment. This is under tab 3 in your packet. We allow individuals to sign up to provide public comment before the meeting, and we will start with those that have signed up to provide comments. When you're called upon, please state your name and affiliation if appropriate before speaking, and we will be displaying a timer as a reminder of the 90-second time limit. When the timer stops, please stop your public comment. Angela, can you start with the names and individuals who've signed up to provide comments?
Yes, I can. First, we have Catherine Lewandowski, followed by Chris Curry. So Catherine, if you'd like to begin.
Thank you, members of the FTAC committee, for allowing me to speak today. My name is Catherine Lewandowski, and I'm a registered nurse here in Washington for over 37 years now. And I am speaking on behalf of myself today. I had hoped to have more prepared for you, but personal business issues kind of got in the way. But I would just like to stress upon you that in the last 8 years that I have been studying our healthcare system here and around the world, and that I have been actively working to reform our broken healthcare system, what I have found is that there have been dedicated people working on this problem in America for decades. None of the previous solutions to deliver cost-effective and comprehensive healthcare to America have been successful. And this is why we had so many unnecessary deaths during this last global pandemic. And I should say few, because some have been successful. Although I hope that you might be able to break through all of this red tape that is by design intended to obstruct you. Sadly, I am doubtful that you will be successful. All of the studies have already been done, and now we only have to figure out the path around all of the obstructions, any path. Unfortunately, until we have a country where bribery of not only our elected officials, but also of our highest judicial body is not only legal, but an accepted norm within our political body, we will be unable to realize the cost savings that we could if we had not ever allowed the for-profit health insurance industry and the medical industrial complex to control our legislative bodies in their favor. I hope that you will do what Oregon has done and keep 100% focused on designing a nonprofit universal healthcare system that values all of our residents as human beings deserving of comprehensive healthcare, and that will eventually lead to a single-payer nonprofit public health system. Please help us to survive the next pandemic, and in the process, have long and productive lives with our families.
Thank you, Catherine. Next will be Chris Curry, followed by Roger Collier. Chris Curry, if you'd like to begin.
Hi, I'm a retired RN from Spokane, member of HCFA. In the meeting materials, Christine Eibner cites Brown, Peisch, and Seidenberg as saying there is no clear statutory pathway enabling CMS to redirect Medicare funds to a state. However, those same authors later state that it might be possible, given CMMI's broad authority for granting waivers. The April 22 California Commission's final report, therefore, recommends that the state actively engage federal authorities to gain a better understanding of what could be accomplished with existing waivers, and then work with these authorities to enact legislation for additional desired waivers. This is exactly what many of us have been advising all along. Regardless of what arrangements for federal funding might look best for us today, nobody will know what is actually possible until we begin an iterative, ongoing conversation with those authorities. The commission should initiate this soon and put any decisions about Medicare on hold for the time being. Thanks.
Thank you, Chris. Next, we have Roger Collier, please, followed by Maureen Brink-Lund. Roger, if you'd like to begin.
Thank you. Let me just start by saying I thought Christine Eibner's Medicare analysis was just terrific. This is just the kind of thing that's been missing from the Commission's efforts so far. Then, looking at the rainbow chart of 6 options in Christine's analysis, I do have some questions. Some of them may turn out to be rhetorical. First, for the state Medigap option, wouldn't some kind of waiver of OPRA be required, as in Massachusetts and Minnesota, especially if it would cover all enrollees, not just those in traditional Medicare? Second, for options 1 through 3, what chance is there really that anyone in DC with an ounce of political savvy would approve a waiver or a law change to transfer 1.5 million seniors, most of them voters, into an untried state program? And third, for option 4, how many Medicare beneficiaries will want to switch to an untried state program when there are already Medicare Advantage plans that offer vision, dental, and hearing coverage? I happen to be in one. And fourth, for option 6, where will the funding come from and how much? And finally, the pitch. Wouldn't the chances of any option be improved if we were proposing to enroll Medicare beneficiaries in a tried and effective state program instead, as I've suggested in the public option proposal included, very fortunately, in your meeting materials? Thank you.
Thank you, Roger. Next, Maureen Brink-Lund, followed by Sarah Weinberg. Maureen, if you'd like to begin.
Yes, hi. My name is Maureen Brinkland. I live in Ballard. I'm retired. And I just want to address a comment that I made to the commission last month, that the bill that established the commission, SB 5399, mandates that the commission design a unified financing system, including but not limited to a single payer financing system. I see little mention of this, for example, in the November report. I don't think it was dealt with at all. I don't hear much conversation about single payer as a goal or a concern in either the report or in these conversations that I've been listening in on. And only a single payer approach can fully reduce the big pointless costs of burdensome and redundant administrative hurdles that our current way of dealing with healthcare manages to cultivate. And on the Medicare question, I just have, in listening to and speaking with people who know more about Medicare than I do, it sounds like we need to start negotiating with HHS soon to find out through iterations of conversations what it is that is required for them to go into our plan, so that we can then have a plan that we can submit as the formal application. So finally, I just want to applaud the funds that were allocated in the budget and give a hands up to the advocates who worked so hard for those funds. And you worked tirelessly on this project, and I see that you can use the additional support. So carry on. Thank you very much.
Thank you, Maureen. Next, Sarah Weinberg, followed by Consuelo Echeverria. Sarah, if you'd like to begin.
Thank you. I have two comments for this meeting. It is really important to pursue the first most inclusive option regarding Medicare. Waivers of some sort are required for anything involving Medicare, and the first option on your list will be the most successful for a relatively simple, single-payer, publicly funded universal healthcare coverage program. It will have the lowest administrative expenses and bring in the most federal dollars, tax dollars to support the program. Our state seniors will find such a program superior to what they're dealing with currently, juggling deductibles, copayments, lack of an upper limit of out-of-pocket expenses, et cetera, under the current very imperfect Medicare, including Medicare disadvantage. Number two, don't be tempted to go down the rabbit hole of value-based purchasing or population-based payment ideas. Neither has been shown to control overall costs, especially since such schemes bring with them larger administrative costs. Other nations have shown that regulated fee-for-service payment for outpatient services combined with global budgeting for hospitals minimizes administrative expenses and doesn't lead to overutilization. Most people are not looking for extra unneeded medical care, so the idea of moral hazard is exaggerated. Yes, fee-for-service payments need to be regulated to prevent those few providers waiting to game the system to their profit. Thank you very much and good luck.
Thank you, Sarah. Next, Consuelo Echeverria.
Can you see me and hear me?
You sound great.
Okay, perfect. First of all, thank you everyone, all commissioner members for their work. And I would like to briefly address 3 points on the May agenda. First of all is the work plan. I think that covering ERISA for the next 5 months is too much time. Considering the strategies outlined in Brown and Mikowski, it shouldn't take almost a half a year to discuss this. I can't emphasize enough that the next 5 months would be better spent focusing on a single payer model, such as the WIST, and also addressing immediate needs, such as suggested by Robert Gantz in the previous meeting. Secondly, the Medicare waivers. I urge the commission to vote for option number 1. As has been mentioned previously, establishing communication with the Department of Health and Human Services can guide this complex and iterative process of preparing the groundwork for Washington State. I would just like to mention, while the presentation of Christine Eibner, and I hope I'm not murdering your name, highlights the real barriers of no precedent and unclear federal support, option 1 is, as the California report states, the North Star that should guide all of our efforts. It is now our time for the moonshot, and we really should take it. Thirdly, population-based payment model, and I cannot urge this strongly enough. We should not adopt a population-based payment model as it is an iteration of value-based payments with its egregious problems that fee-for-service does not have. It incentivizes providers to treat those that are healthy and drop those that are sick. Am I done? Anyway, the rest is in my comments. Am I done?
That's time, Consuelo. Thank you.
Yeah.
Okay, and that is it for who has signed up. Is there anyone else who'd like to provide comments in the last few minutes that we have? Please raise your hand on Zoom. Give just another minute here. All right, I am not seeing any more hands, Pam, so we will go ahead and move forward. And just a reminder, if you're not a member of the committee, please do turn off your camera and mute your microphones. Thank you.
Okay, thank you. Thank you to everyone who took the time to comment today. This is a really important part of our process, and we appreciate your efforts to do this. I'm going to turn it over to Liz Arjun from HMA, who will briefly share our work plan with us. This is going to be a quick item, but it's really important that we touch base on the work
Everybody,
plan,
I'm
where we've
not.
been and where we're going forward. So thanks. Go ahead, Liz.
Thanks, Pam. Sorry, my volume is weird. And of course, I'm in my office, and that's when things get weird with the internet. So I apologize if I get kicked out. Just always a quick reminder of where we're at and what the expectation is for today and how it fits into the rest of the year. Today, here we are in May, and this is our original work plan. Again, it's going to be changing over the course of the year as we move through things quicker or slower than we anticipated. But today we're focused on providing some direction about the role of Medicare and where it fits in the design process. I think it's really important to understand that this is not about whether or not Medicare is going to be addressed or that Washington Medicare recipients are able to benefit from the system that's designed. It's just about what pathway will allow the commission to move forward as quickly as possible in designing the system. And this really follows a conversation from 2 months ago when Chair Lowe presented about different ways that they have been able to address and fill in gaps for Medicare populations in the Jamestown-Slalom tribal system. So after today, we'll be hopefully the goal is to provide some guidance to the commission. And we'll come back together again in July, hopefully moving on to another topic focused on the design process. I'm sorry, I just heard some, I don't know if I'm cutting out. Can you hear me, Pam?
Yes.
Oh, sorry. I just heard a weird echo. We'll get some feedback from the commission and come back again and look at ERISA. And depending on where we're at, we may move faster at that point. But as you can see, we're going to be continuing to follow the guidance of the commission throughout the year about what they need information on. We'll talk about this a bit later, but we did share information from the FTAC with the commission about transitional solutions. And unfortunately, they did not get a chance to talk about that at their last meeting, but that is also something that we want to make sure you're aware of what's happening there. And we'll talk about that later. So I hope that helps everyone understand where we're at and where we're going throughout the rest of the year.
Okay. Thank you, Liz. That was really helpful in terms of context for the next discussion and also just to kind of ground us in where we are in the work. We're going to move on to our Medicare discussion. At our last meeting, we had a preliminary discussion on Medicare options. And with Christine's presentation and our discussion today, the goal is to come away today with, from this meeting, with guidance for the commission on a Medicare waiver and to make recommendations on options to include Medicare in Washington system. And as we go to identify the pros and cons of the Medicare options that we'll be proposing. There will be several points during the presentation where we can pause and discuss, and we won't be voting on anything until after Christine's full presentation. Christine is a senior economist at the RAND Corporation, and I think we're really lucky to have her guide us through the discussion today. We're going to use, you need to go back to your packet. We're under tab 5. And given time, I'd like to move on, let Christine start, but I'm really looking forward to a really healthy, vibrant discussion on these topics. Christine?
Thank you, Pam. Thank you for that introduction. So I think we can move to the next slide. So this is just a brief overview of where we're going to go with this presentation. I'll start by providing some background on Medicare and the UHC plan and how they sort of relate to each other. Then I'll go through sort of the heart of the presentation, which is a discussion of the options for incorporating Medicare into the Universal Healthcare Plan. And then we'll discuss some specific issues related to the treatment of low-income beneficiaries. And then finally, some summary and discussion. So we can move to the next slide. So this is my overview slide of Medicare, and I know many of you are familiar with Medicare, but I thought it would help to sort of, come from the same starting point. So this is the federal health insurance program for people ages 65 and over or qualifying people with disabilities. And there are 4 components, which I've shown in the table. Part A is the component for hospital care, and that's what we pay for over the years with taxes, our hospital insurance taxes. And this is the one component of Medicare that doesn't have a premium. So if you've had 10 calendar quarters of, 40 calendar quarters of paying the hospital insurance tax, you're automatically eligible for Medicare Part A. Then the other components include Part B. So that's physician services or other medical care that's not hospital care. And that does require a premium. So it's 25% of the total cost, and higher income beneficiaries pay a little bit more. Part C is also known as Medicare Advantage. This combines Part A and Part B into a single health plan. And then it's offered through a managed care provider. And then finally, Part D is prescription drug coverage. And prescription drug coverage is its own plan that can be bought alongside Part A and Part B, or sometimes it's rolled into a Part C plan. So you have what's called an MAPD plan. So that's a Medicare Advantage and prescription drug plan. So a couple important things to keep in mind. Most of these components of Medicare do require some premium. So Part B definitely, Part D usually has a premium. Part C can have a premium depending on sort of specifics of how that plan is operated. But even if you don't pay a Part C premium, you would generally pay a Part B premium. Another feature of Medicare to keep in mind is that it covers about 80–85% of beneficiaries' total healthcare cost. So that's comparable to an employer health insurance plan, but it doesn't cover 100% of the cost. And then the way that the federal government pays for Medicare is that it reimburses providers or plans for the services. So if it's traditional Medicare, so that's Part A and B, providers are reimbursed directly by the federal government. If it is a Medicare Advantage plan, then the federal government is paying that Medicare Advantage plan, and then the plan is managing the care for the beneficiary. But there's right now, unlike Medicaid, there's no role for the state right now in terms of how that payment is transferred. It goes from the federal government to providers or plans. Okay, so we can move to the next slide. So just some high-level thoughts about why it might be important to incorporate Medicare beneficiaries into the UHC plan. So according to the Universal Healthcare Commission's 2022 report, the goal of the UHC is to have no premiums, but of course Medicare does have premiums. And so one reason to roll Medicare beneficiaries into the UHC plan might be to avoid those premium charges. Another rationale for bringing Medicare beneficiaries into the UHC is that in the benefit design options that were outlined by the commission, design options A and B had no cost sharing, whereas Medicare does have cost sharing. So rolling Medicare beneficiaries into UHC would be a way to achieve parity with respect to cost sharing, especially if the state goes in the direction of having no cost sharing. And then it's also the case that the Universal Healthcare Commission envisioned at least offering vision care as part of the UHC, and possibly maybe other benefits like dental and long-term care. That is none of those benefits are included in Medicare, although they are sometimes offered through a Medicare Advantage plan, but they don't have to be. So it's not a guaranteed benefit. Okay, we can move to the next slide. All right, so now I'm going to move to the discussion of a range of options for incorporating Medicare into the Universal Healthcare Plan. So we can flip from this roadmap. So these are the 6 options I'm going to cover. And you can see I've put an arrow that's sort of showing the least feasible, the most feasible. That is pretty subjective. That's just based on my own read of the literature and information, although I tried to draw from the California report as well as the Oregon report in making this assessment. But please keep in mind that's, my subjective assessment there. So we'll start with the act of Congress or comprehensive waiver. And we can go to the next slide to discuss that. So this would, I think someone referred to this as the North Star. So the goal of this would be for the state to recoup the money the federal government is currently spending on Medicare and bring it into the state revenue to be spent on this universal healthcare plan. So that's sort of the North Star. You'd be able to bring in all the beneficiaries into this universal healthcare plan. And the state would be recapturing the federal government's contribution. So this is, it's an interesting idea, but there are some disadvantages. So there is no precedent for something of this magnitude happening, where a state recoups Medicare funding. There's really no precedent for that. And the legal advisors to the state of California in the memo that was circulated also said that they found no clear statutory or regulatory pathway that would enable CMS to redirect Medicare funds to a state, even via waiver. And important to consider is that previous point that I made, that right now that's not how Medicare operates. It's paying providers or it's paying health plans. It's not paying states. So that would be a very significant change in how Medicare is operated. So it's possible that we would even need, or that Washington state would need an act of Congress in order for such a change to occur. And I don't know, again, this is subjective, but just my read right now is that President Biden has made preserving Medicare a cornerstone of his 2024 campaign, and moving to, allowing a system that sort of took Medicare beneficiaries and moved them to something else, even, a state operated plan, might kind of undermine that message. So I think it might be politically risky for the administration, which could sort of lower the chance that this could be feasible. And then on top of all of that, beneficiaries may still owe premiums, right? Because the only part of Medicare that doesn't require a premium is Part A, but to recoup the federal funding for Part B or Part D, it's really unclear to me how that would work and whether there might still be a premium requirement for beneficiaries in order for them to receive that. So we can move to the next slide. So another sort of related option is a demonstration waiver. And this is the other option that came up and was discussed in the California report. So in this case, Washington State would work with CMS to develop a reform that could be implemented by 1115A or 402B waiver. And this is something that has been done. There's precedent, right? So Maryland has a waiver like this for their total cost of care model, and Vermont has a waiver like this for the Vermont all-payer system that they have in place right now. So if, potentially this could allow the state to capture federal funding for Medicare, but there are some constraints around a demonstration waiver that would have to be kept in mind pursuing this route. So the waiver authority really focuses on payment reform. So that's changing how providers are paid, how health plans are paid. It's unclear how this option could be used to cover other aspects of benefit design, premiums, cost sharing, additional benefits, those sorts of things. Now, it may be feasible, right? But the state would have to think fairly carefully, or the commission would have to think fairly carefully about how do we create an option that is payment focused, but brings in these other components. So that would require some careful thought. Another aspect of these demonstration waivers is that the statutory authority allowing them to go forward requires that they either reduce federal spending without reducing quality of care, or that they increase the quality of care without increasing spending. So this is a high bar. So there was I guess 2021, there was an article published in Health Affairs by Takeda Brooks-LaShore, the commissioner of CMS. And, they found that in the first 10 years that these waivers were available, they tested around 50 models out of the Innovation Center at CMS. And they found that only 4 met this bar of either reducing spending without reducing quality, or increasing quality without increasing spending. So it's a high bar. It may be difficult to sort of make the case that, that this is going to achieve the goals. Because of this high bar, and partly because of this high bar, that this type of waiver is subject to monitoring, evaluation, and periodic redetermination. And then it's also possible that it could be subject to legal challenges. So, for example, if this precluded beneficiaries from enrolling in a Medicare Advantage plan, then there might be, grounds for beneficiaries to pursue legal action. And I'm not a lawyer. I don't know how likely that is, but I do know that, the ACA has gotten a lot of different challenges, and I would imagine something like this could also engender charges from beneficiaries who felt, for whatever reason, that they didn't, they had been harmed. So that's the demonstration waiver option. So we can go to the next slide. So I want to pause for some questions and discussion around these first 2 options. And I just want to note that there's going to be a formal vote on this topic that will follow the presentation, as Pam noted. So let me open it up to others.
So this is Roger, and I guess I would concur with you that along this notion of an absence of a clear pathway. When I read the language and reports, at least at this juncture for me, one that suggests not a clear pathway. And along the, if you will, the 1115 demonstration ones, I think you also talked about that as this notion, at least in the Medicaid world, we call it budget neutrality, which is a similar concept. And I see that embedded so far in, for example, the waiver that Maryland has for its all-payer hospital system. It may call it a little bit differently, but essentially at the end of the day, you're going to have to demonstrate that it creates no more greater costs for the federal government that would be absent that waiver. So I see that implicit in the 1115A, as well as the Medicaid's in the past, their 1115 small a approach.
Yes, thank you, Roger. I agree. I think that the budget neutrality is a key component of those 1115A waivers.
Christine, this is David. I had a couple of thoughts. First, I just want to say thank you for putting this all together. It makes it a lot easier to think about additional pros and cons when somebody like you has already done this hard lifting. And Roger, for that matter, you sent out some materials ahead of time that I appreciate as well. I've worked in Medicare Advantage for a while, and I still learned something from reading what you sent out, so I appreciate that. And just lastly, I appreciate the public comments as well. It's helpful to hear a range of opinions to challenge what I'm thinking and enhance what I'm thinking. So Christine, back to this, I was struggling initially with why the commission is focusing on rolling Medicare into a unified system first, as opposed to insuring uninsured individuals or underinsured individuals, since Medicare is a fairly robust insurance program. So I went back to the September report, and reading through the text about Model A and the tables about Model A, it seems to me that the commission's primary objective with bringing Medicare under the fold is to create a vehicle to lower commercial fee schedules and extract savings system-wide from that. And there's a table in the September report that shows $8 billion in savings from that mechanism on the commercial side, with relatively flat expense on the Medicare side. So when I think about that as the primary objective, to me, option number one is really the only effective method of the 6 options to achieve that objective of the commission. And I'm curious if you've thought about that or have any reaction to that.
Can you say a little bit more about why that would be the only? Yeah, I'd like to just hear your logic there.
Yeah, so I suppose number 2 might be a vehicle there. Number 2 seemed to give the state less flexibility and control over the full system. So the idea behind Model A is you take all the different existing market segments, combine them into one, and create a unified fee schedule. And then that fee schedule unification, bringing the commercial rates down, bringing Medicaid rates up, and it's not clear to me whether Medicare rates stay the same or move up or down slightly. So I'm thinking that this comprehensive waiver would give the state the authority to do something substantial and drastic like that. Politically, that would be extremely difficult. It's going to be extremely difficult under any scenario. I'm not sure if number 2 achieves that, but when we start getting into the state, like option 3 and option 4, I don't think the state creating a Medicare Advantage plan gives it any leverage to modify the commercial fee schedule.
Right. Well, so yeah, I mean, option 2 that is kind of what Maryland has right now, and Maryland does have, they've modified the fee schedule to achieve sort of, I think there is a adjustment for Medicare and Medicaid, but it's generally one rate. But you may, yeah, I think that your logic sounds right. But of course, I mean, if the state were operating its own Medicare Advantage plan, it would have a lot of leverage to, negotiate payments with providers. So it would sort of bring that into, potentially that it could achieve some of those goals that way as well.
Yeah, I think if the state was operating its own plan, it could do that on the Medicare side, but it wouldn't be necessarily facilitating a unified system where then it could create those fee schedule similarities.
Right.
Got your question too. This is Roger. Excuse for interrupting, but it's interesting because when I first read option 1 and 2. A comment again. One is, as we've talked about, to a degree, bringing Medicare into a unified system is what the enabling legislation, at least in theory, calls out. And we've used the metaphor of a North Star. And when I read option number 2, when I first read it, to say, well, we're not sure we can't find an existing clear pathway, but maybe the 1115A is a backdoor to get there. In other words, it would be trying to use some of the enabling language that gives CMS broad latitude to waive a variety of things in Title 18. There's that language that sits in there. So one can make the arguments that say, well, maybe that's the vehicle you could use to do a comprehensive waiver. So that's how I kind of read option, if you will, option 2. And maybe Christine, I was off base on that.
No, I think that's right. I think that Robert Murray has his hand up. Oh, you're on mute.
Thought I clicked that off. I have some experiences to having been working in Maryland with the option 2, a demonstration waiver. Is that necessarily mutually exclusive with some of the other options like 3, 4? I'm not a fan of waiting for Congress to act. I think there's paralysis at the national level, and that's non-starter. But demonstration waivers in the context of a payment model, and we're going to talk about different payment models later, is an entirely feasible approach. And I can talk more about Maryland's waiver, but could a state also pursue, in addition to demonstration waiver in the context of a payment model, also pursue, say, state-operated MA plan simultaneously? Are they mutually exclusive?
I don't think they necessarily would be. So those 2 options in particular might be difficult, right? Because the state-operated, if you're talking about option 3, right, where it's the state is the only operator of the Medicare Advantage plan, maybe that could be done by a waiver somehow. By 1115A waiver, but that's like another big waiver that's needed. So like combining those 2 things is that one's hard for me to wrap my head around how exactly that would work, but it might work. But I think in general, yeah, like some of these things could be combined. So for example, having a state-operated Medicare Advantage plan under number 4, where it's not legally the only option for residents, and so that reduces the legal bar. And then having a Medigap plan, that seems like totally feasible. Right.
Yeah, I just wanted to clarify. So, but my own experience with the option 2 is it is feasible in the context of a payment model. So anyway.
Yeah. So I don't see a clock in my view. I want to make sure I'm not, maybe I should move on because we have a lot to cover.
David had his hand up. Is it?
Oh, I didn't see, sorry.
Oh, that's fine. Given, Robert, I appreciate your question, and I have to log off at 4 o'clock, so I'll just piggyback off your comment about combining options. I think whether it's 1 or 2, and if that primary purpose is this vehicle to do something that's going to be politically very challenging, I'm drawn to the idea of pursuing 1 or 2 on a long-term basis, potentially partnering with Oregon and California to increase the leverage at CMS or at Congress. In the short term, pursue an option like option 4, which would be a half step to give the state some experience with the dynamics, and then pursue option 6 simultaneously to achieve the cost sharing reduction objectives. So that's all I want to say. Thanks, Christine.
That's great. That was great, David, especially since you have to leave early. I really appreciate that. Christine, why don't let's move ahead so we can.
Sure, that's great. Yeah. Okay, so now I'll turn to options 3 and 4 and see that these are different flavors of a state-operated Medicare Advantage plan. And so for option 3, the state-operated Medicare Advantage plan would become the only option for state residents. So this would allow the state to transition Medicare beneficiaries into a plan that could be potentially designed, to the extent that Medicare Advantage rules allow, it could be designed to offer the same benefits as the rest of the universal system. So, potentially from the beneficiary's perspective, this looks exactly the same as the universal health system or universal health care plan, just depending on how exactly what is allowable. So that's the advantage of this approach. The disadvantages are this would require a waiver of a provision that allows choice between traditional Medicare and Medicare Advantage, as well as a mechanism to preclude private Medicare Advantage plans from entering the market. So that's like a legal complexity that would have to be addressed to move this forward. Another issue that I raised last time is that Medicare Advantage payment is pegged to a fee-for-service benchmark, which is based on the cost of traditional Medicare, Parts A and B. And so I'm not sure how that would be resolved if you had a Medicare Advantage plan with no fee-for-service. How would payment be set? So that's a hurdle. The Medicare Advantage pricing and benefit design requirements could limit flexibility. Alongside that, the state would have to apply to become a Medicare Advantage organization, or else they'd have to contract with a Medicare Advantage organization in order to offer a Medicare Advantage plan. And then, potentially this one is also subject to legal challenges. And in my read of the California document by Brown and colleagues was that this is even more likely than the previous one to lead to a legal challenge, because, beneficiaries may have a stronger case to make that they have a right to traditional Medicare, and that if that was eliminated, that would be problematic. So that's the summary of option 3. We can move on to option 4. So this is another flavor of a state-operated Medicare Advantage plan in which there's still competition. So beneficiaries can still choose to go into traditional Medicare. They can choose to go into another non-state Medicare Advantage plan, but the state could design a plan that, they were really trying to make attractive to beneficiaries. And that could be a way of offering the universal health coverage, the healthcare plan to Medicare beneficiaries with fewer legal challenges, because now you're not taking away the beneficiary's choice. So you're sort of using a carrot rather than a stick in order to, beneficiaries may wish to enroll in this plan. So that is an advantage of this approach. But we still have some of the disadvantages outlined with the previous option. So one is the state would still need to design and manage this plan. The Medicare Advantage pricing and benefit design requirements could limit its flexibility. The state would still need to become an MAO or contract with an existing MAO. And then, some beneficiaries could opt not to enroll. And then, that's another situation, but you haven't necessarily got all the beneficiaries in this plan. Okay, so let's move to the next slide, which I think is the discussion for this. Yeah, so happy to hear comments or what others think about these two options. It looks like Eddie has his hand raised.
Yeah, my question, when a state would do this, what would happen when a participant would go outside of the state? Would they also then keep the plan? Or maybe this is a technicality not really worth discussing at this point, but would then you also be competing with people that aren't in the state that could enroll in your plan as well?
Right now under Medicare Advantage, if you do move out of state, you have to enroll. My understanding is you have to
open enrollment. Yeah.
And so I think that would be the same. I don't see how that would be changed under this option. And I also, I don't think, David, it's possible that I don't believe that Medicare Advantage plans typically cross state lines, although there may be cases. I don't know. I defer to David if he knows the answer, or Roger may know. He has his hand up.
Roger, do you want to take a crack at it? I think you're on mute.
My understanding would be is of an individual residents remained in the state and an emergency condition occurred out of state, their plan would be obligated to cover that emergency intervention and make a decision, as to whether the complete treatment ought to be completed out of state or bring them back in state. If somebody's primary residence, moved out from Washington to somewhere else, then they would disenroll from the existing plan and enroll either in Medicare fee-for-service or in a plan that was available in their new geographic location. So that aspect would be just as Medicare advantages today, I guess what I'm trying to say.
Thank you.
Can I have one other thing? We're talking about the plans, just a reminder that a little bit I put together is that in our state today, as I best understand it, there's something like 18 carriers that offer Medicare Advantage plans in our state. They offer approximately 100 plans, different types of plans. And 40 of those plans are no premium plans. Their offerage is statewide. That is, throughout all 39 counties, there are three or more plans in any one given county. So I think I guess my comment here is, as we're talking about these options, there is an existing delivery system out there, a robust one that would have to be contended with one way or the other.
Agree. Good point. It looks like Kai has his hand raised.
Yeah, thanks for these comments. So one point to statute, which you said, Christine, earlier, is that there's going to be like substantial administrative burden, right, associated with state administration of MA plans. But the second point is, like, although these are two separate options, seems like functionally they could be very similar if the goal of these state operated MA plans is to get close to or achieve benefits parity with UHC. Then you would think that individuals in the option 4, even if they had a choice, would gravitate towards these state MA plans. So then, functionally, you would achieve the same goal, and then you would, probably face a decent amount of sort of pushback in both of these, right, from the existing MA insurers.
Yeah, I wondered about that, and I didn't get into these slides, but so, I don't think it would be possible given the way that Medicare, so Medicare Advantage, I think, as folks probably know, if you price competitively or if you bid competitively with CMS, you can get a rebate back from CMS and use that to buy down premiums or to buy down or to add extra benefits to your Medicare Advantage plan. I looked into that a little bit. I think it would be difficult to price so competitively with a state operated plan, to bid so competitively that that you could sort of add all the bells and whistles to get to this, what the UHC would want to look like. Maybe, I think, I'm not an actuary, but I think that would be really tricky. So then there's this question of what could be offered and can you go above? There's an actuarial certification that has to happen when you bid on your Medicare Advantage plan. So if a state, if an insurer were to submit a bid that looked, too generous relative to what it was kind of charging CMS and the beneficiaries, it might be rejected on those grounds, right? And so I don't know if the state jumped in and did that. So this might be a case where that would have to be combined with direct reimbursement in order to achieve that. Or it might look much more similar to a traditional, or no, I shouldn't use the word traditional here, to a typical Medicare Advantage plan, in which case there would be more competition. So I think that would be another, it's a little bit weedy, but I wondered about that. David, you've got your hand up.
Yeah, Christine, what you just articulated are some of the thoughts that I've had. And, I wish we had a half a day to talk about all these options because, these are just initial thoughts, I think, at least from my perspective. When I think about number 3, it seems like the political hurdles required to achieve that are overlap significantly with the political hurdles to achieve number 1. And so I'm not sure why it would make sense to pursue 3 without pursuing 1. I think 4 is the most feasible in the sense that the state currently has experience partnering with health plans on PEBB and Apple Health. And as I mentioned earlier, this could be a potential step for, a halfway step toward a unified system where the state could gather experience about what it means to be in Medicare Advantage.
Thank you. And Roger also seems to has his hand up. Roger?
Yeah. Yes, let's just back on option 3, if I might. Yeah. One thing that comes to mind is well, I guess around both of these, if there is a state-only plan, I mean, there would be one model to say the state itself is going to administer the plan itself, or contract, and I'll give an example today with Uniform Medical, but UMP, where they contract, in this case with Regions, to be an ASO for the state. So that's, you know, one model. The other is to turn around and contract with an existing plan to be, you know, be the Medicaid, I'm sorry, the Medicare Advantage plan for the state. And I don't know quite how that would work, because you say we're going to kick out the 18 plans, but we want to have somebody come in and, you know, to be a state-only plan. I think that, as we've talked about, would be quite a challenge. And then the last thing, just as we're thinking about today, you know, in terms of the state's current capacity, just this is a reminder, most of what we, through the healthcare authority, deliver, with the exception of a bit with the Medicaid fee-for-service program, it's either through health plans that we contract with, or APRA Health, or the exchange for their plans, or for PEBB or SEB, or the Uniform Medical Plan is again one where we contract with an ASO. I think what I'm trying to say with that is that the state today does not have a major infrastructure in place for itself to administer its own plan, if I'm making sense, to be the actual administrative entity of it. It would need to build that. It doesn't exist robustly today. And I'm seeing you nod your head. Would you concur with that?
Yes, absolutely. And it is, it's no small thing to build that kind of an infrastructure. I just think of a lot of operational and consumer issues as we look at these. I mean, one is that consumers can be very attached to the plans that they have. Sometimes it's very rational, sometimes it's not even rational. It's just that that's what they're used to. That's their connections to their doctors and so forth. So restricting choice can be problematic. But then the trade-off there is you can generally gain a lot more in terms of value of the plan if you restrict choice. I think that, we had come down, should the commission spend time on this option? I think those are really critical in each option, because the time you spend on those is time taken away from implementation of somewhere else. So sort of how we would phase these is a really critical part of the thinking.
Thank you. So should we move on, or are there other comments on this slide? Looks like maybe we can move on.
Okay.
Great. Okay, so now I'm going to go to the last two options. So option 5 is a state-operated Medigap plan. So this would offer, the state would offer a Medigap plan that's a supplemental plan that fills in gaps between Medicare and the universal healthcare plan. So, in theory, this sounds like a good way to provide more comprehensive benefits than traditional Medicare. In looking into this, Medigap plans face a lot of restrictions, which might make it difficult to use this avenue to fill in the gaps. So first of all, they have to have 1 of 10 specific benefit designs. They don't include dental, vision, or supplementary drug coverage. There's a weird requirement that they have to offer, so these 10 designs are labeled with letters. So the Medigap plan has to offer design A, the insurer offering a Medigap plan has to offer design A, which is the least generous option. And then they also have to either offer design C or design F. Design C and design F are strange. So there was a law that was passed in 2020, made it impossible for Medigap plans to cover the Part B deductible. So all Medigap plans, or all Medigap enrollees going forward, cannot have their Part B deductible covered. However, because that people who had coverage prior to January 1st of 2020 were grandfathered in to be eligible to have their Part B deductible covered. So C and F are the two designs that offer the Part B coverage for the Part B deductible. So insurers are required to offer one of these two designs, although it can only be sold to people who were enrolled prior to January 1st of 2020. So that's a little convoluted, but complicated situation there. This is not available to Medicare Advantage enrollees. And then another sort of distinguishing factor from this and the other options that we just talked about is all of those other options would bring some federal funding into the state to manage the benefit that they're creating, whereas this would not. So this would be the state has to find funding for it or charge beneficiaries premiums or do something, but there's no federal stream of funding that would be recouped through this mechanism. I guess I should mention that there are some states that have waivers that have allowed different benefit designs under Medigap. And I don't know all the details of that, but I do know that it does not get around all of these requirements. So this Part B deductible, for example, is the fact that plans going forward cannot cover the Part B deductible, that applies to the waiver states as well. So there are still constraints even with a waiver, at least based on the experience we have to date. Okay, so let's move to slide 6. So slide 6 is then sort of just kind of getting around all of this and just saying, let's just reimburse or insure beneficiaries directly for gaps. So, you know, in this case, you know, Washington State would reimburse beneficiaries for Medicare cost sharing or for services that are not covered by Medicare, but that are included in the UHC. And so this would be a way of getting, you know, substantial flexibility to fill in gaps and equalize coverage across the Medicare population and people enrolled in the UHC. There are the disadvantages, and I have another slide to cover this because this is also a little complicated. You know, the gaps depend to some degree on beneficiary choice, right? And so depending on how generous the state would be in terms of filling in gaps, it could lead to, you know, beneficiaries acting strategically to reduce their own cost and then putting more cost onto the state, which may be undesired. It could also be subject to gaming from Medicare Advantage plans, and I'll talk about that a little bit more in the next slide. I just talked about this, this rule for the Medigap plans where the Part B deductible can't be covered. The reason for that is that MedPAC has argued that if the Part B deductible is covered, it creates moral hazard, right? It leads to more people using more care, perhaps unnecessary care, and it leads to moral hazard and creates an additional cost for the federal government because, you know, the deductible, because they're using more care, the federal government shoulders more burden. And so that's why that's not allowed. And so if the state were to offer to cover the Part B deductible, I'm not sure whether that would lead to federal scrutiny over that because of this MedPAC determination and then subsequently the law that eliminated that in Medigap plans. Like the other option that I just discussed, there would be no opportunity to recoup federal funding here. And this could be administratively complicated. I mean, all of the options are administratively just have administrative complications. But in this case, the state would have to, you know, document, figure out which services are reimbursable and which are not reimbursable, and that could be difficult. So I want to move to the next slide because I have a little more detail here about some of these points that I made, just to make sure we're all on the same page. So, you know, if the state just said, oh, we'll reimburse for, you know, services that are not covered by Medicare, well, you know, as I mentioned earlier, you have to pay a deductible to have Part B coverage. Otherwise, you don't get Part B coverage. So what if a beneficiary says, oh, I'm not going to pay my Part B, you have to pay a premium. I think I mixed up the term premium and deductible. Apologies for that. You have to pay a premium to get Part B. So what if the beneficiary says, I'm not going to pay the premium? Well, that would shift all the costs for Part B onto the state if the state is willing to reimburse coverage that isn't included in the person's Medicare benefit. And so, you know, the same thing could happen with Part D. You usually have to pay a premium. So if a beneficiary decides just not to enroll, then the state could end up shouldering all the cost of drugs. So, you know, then the state would have to set up some rules, right? They'd have to provide direct reimbursement only as a wraparound approach. You know, would the state then jump in and pay the premium? What about higher income enrollees, you know, who face higher premiums? What about, you know, for Part D, there's different plans you could choose, you know, are you required to choose a certain type of plan in order to get the state wraparound? So there are a lot of like other questions that would raise if we take that approach. The other point that I made is that this could cause, you know, some some gaming on behalf of Medicare Advantage plans. The issue is here is those rebates that I talked about. So Medicare Advantage plans can be eligible for these rebates for the federal government, from the federal government, that they can use either to buy down premiums, to buy down cost sharing, or to add supplemental benefits to their package. So if the state were going to reimburse for things that are, their plan isn't covering, depending on what the parameters of that reimbursement is, that Medicare Advantage plan might strategically want to shift to starting to offer supplemental benefits that are not included in UHC, spending the rebate dollars on that to attract beneficiaries, and then letting beneficiaries go to the state to get, the reduced cost sharing or the kinds of benefits that are included in the UHC. So it could end up shifting costs from the Medicare Advantage program into the state budget through this rebate mechanism. So that's another issue here. And so I think we can go to the next slide and open this up for discussion. Any comments, pros, cons, other thoughts about these two options? Roger.
All right. So a couple of thoughts on that. When I look at the option number 5, the Medigap plan, as I see that, it's a way of trying to cover, in particular for lower income persons, but persons in general, what might be otherwise out-of-pocket costs for co-payments, deductibles, etc. I would offer that today we do have a program in place. All states do. It's called the Medicare Savings Program, and it makes available, at least for a person up to 100% of federal poverty level, of covering, their Part B premiums and otherwise out-of-pocket costs that they might incur in terms of point of service. And today in our own state, there's about 150,000 people. I'm sorry, I'm mixing two things. About 230,000 people, 36,000 people that get that Medicare cost sharing coverage. Secondly, with respect to option number 5, our state itself, the legislature this last session, or this current session, appropriated about $6.3 million to increase the coverage level for what's called qualified Medicare beneficiaries. That's the full scope coverage one, from 100% of the federal poverty level up to 110% of the federal poverty level. Now, why that isn't necessarily a huge increase, it does provide, a pathway, an existing pathway, if you will, to address some of the issues outlined in option number 5. And I would add to that that there is not only state funding for that, but Title 19 coverage for it. So it's a vehicle, it's available to the state now. It can draw a federal match to it. And then number 6, which is somewhat the same. When I look at that, it says to me what we're trying to do there is to expand, if you will, benefits that aren't today otherwise covered by Medicare. Dental is always a good one, hearing, vision, personal care. A great one is long-term care, which we'll hopefully set aside for the moment. And again, here there's a vehicle in place today to do that in the Medicaid program. It's called full dual eligible Medicare Medicaid beneficiaries. And given the income levels of that, if you qualify as an elderly person, you essentially get full scope Medicaid coverage that wraps around Medicare, which the combination of is as broad as coverage that you will find anywhere. And which we'll maybe talk about when we're considering our recommendations. There are vehicles in place where we could increase that coverage level for those full scope, dual eligible persons. So I guess what I'm trying to say for both of these, there are some existing options in place. The state is already pursuing some of those that could address what 5 and 6 are trying to do, certainly for lower income individuals. Am I making sense there at all?
Yeah. Thank you for that. Yes, I think I see what you're saying. So you're saying like you extend the eligibility for basically dual coverage up the income scale. you know, potentially that federal government may say, no, that's too high, but then Washington State could just kick in the difference for those higher income people. And it gives you a lot of flexibility to sort of tailor where you put that threshold.
Well, and I'll add to, I did a quick look through some Kaiser Commission's work. They went through a lot of work where states are in the Medicaid program. And there are, I think, something like 28 states that already have higher income levels for what we call the full dual eligibles. There are several waiver ways. Again, I won't, take our time today, but there are existing vehicles to raise those levels. I say again, some 28 states have already done that.
Mm-hmm.
And again, by doing that, you continue to draw federal Medicaid coverage for that.
Yep. Okay. So it looks like Kai has his hand up.
Thanks. I just wanted to check my understanding on two things that you presented related to option number 5. One is, your comment regarding not sort of recouping federal funding for this. While that may be true, so wondering, given that we know that these Medicare plans, in that they reduce cost sharing, will increase, sort of the usage of the fee-for-service benefit, right?
Right.
Reducing deductibles and copays and whatever co-insurance. Then, while it's true that no direct funds will be flowing to the state, it will increase essentially the effectiveness or the richness of the benefit for the Washington State beneficiaries themselves. So effectively, there is some increase in federal funding. The sort of per federal beneficiary, Washington State Medicare beneficiary spend would increase as a result of that.
Yeah, I agree. That's a good point.
I just wanted to check on that. And the second point is, I was wondering, this option number 5, does it refer to both state offering Medicare, Medigap plans, as well as covering the premium for those plans? If the latter is true, then given that there's a diversity of these Medigap plans, what would preclude a beneficiary from just selecting the most generous of those plans, right? And with that sort of that consideration regarding the disparities between those plans that you discussed, then not be so much of an issue, because the vast majority of individuals would enroll in just the most generous of those plans.
Yes, so I think you're right. So if the state were to reimburse the premium as well, then it would make sense that the beneficiary would simply enroll, even if there were a requirement to offer the A, which is the least generous. There is still this issue that it's not possible to cover the Part B, that it would have to adhere to these benefit designs or have some kind of waiver, and there would be no possibility of covering the Part B deductible for beneficiaries who enrolled after January 1st of 2020. So that would be difficult to surmount, but I think you're right on the other points. Thank you. Eddie.
Yeah, I had a question. With the Medigap plans that are currently offered, so these wouldn't be the people that are advantaged. These are only the people that have Part A, Part B, right?
That's
or is it? Okay.
Oh, it's only A and B. Yeah.
Got it.
Roger.
Yeah, this is a comment on option number 6, and we've kind of alluded to this in some of the previous options, but we make a reference today to these Medigap plans to equating to what would be covered under our health benefit program, Washington's health benefit program. And it raises, to me, a very profound issue insofar as moving that direction right now would be challenging, given the fact that we don't have a benefit design to point to. So part of the issue is we want to have, equate to a Medigap plan, but the question is indexed against what? So I think that, I guess what I'm trying to say, that poses a challenge for option number 6 until the commission, our own work says, here is our proposed benefit design. Then again, what are the options we have of using or getting Medicare beneficiaries in whatever status they have to that benefit design? But we don't have that benefit design yet. I guess I would offer that poses another challenge for us, if I'm making sense.
I think it does make sense. I mean, that's true for many of the options, right? So like designing a Medicare Advantage plan that the state would offer, if we're not sure what the UHC plan is going to look like, then you if to design it for parity, you can't quite do that without knowing. So, but yeah, I take your point. I mean, that there's a chicken and egg problem. Other comments, questions? Okay, well, maybe we can move on.
Okay.
Okay, so we're going to talk about some specific issues relevant to low-income beneficiaries. So I think, Roger, this will get to some of the points you were making before, so we can go to the next slide. So I just wanted to point out that there are different ways. There's additional funding available for low-income beneficiaries that I think Washington State wants to at least retain and, potentially in Roger's scenario, expand. So there are two programs. One is dual eligibility, and under dual eligibility, Medicaid provides wraparound coverage for low-income Medicare beneficiaries. So this essentially covers most cost sharing. It covers premiums. Right now, I put the eligibility threshold for Washington State. So income has to be under $914 a month for a single person, or $1,371 if married. There's also an asset test currently, but of course this could be changed, and some states have broader, more generous programs. And then the benefit design, exactly what's covered under dual eligibility varies with income. So some lower income duals are eligible for more than higher income duals, but it's pretty generous. There's a lot of wraparound coverage that's provided. And there's also something called the Part D low income subsidy. And this is offered by the federal government. It's not through Medicaid. And this is where the federal government provides lower cost sharing and premium subsidies for low income Part D enrollees. So recall Part D is the drug coverage benefit. And so this extends a little higher above dual eligibility in terms of the income limit. So basically all duals are eligible for LIS, but not all LIS beneficiaries are eligible for dual or dually eligible for Medicaid. And so the income threshold is 135% of FPL for full coverage, and then up to 150% of FPL, if that's federal poverty line. There is partial coverage, but it's not as generous as the up to 135% coverage that's available. And there's also an asset test for low income subsidy status. So those are two things to keep in mind. And if we go to the next slide, some considerations here. So one important consideration is to maintain federal funding for these programs. It's likely that Washington State would have to operate a shadow eligibility system to sort of prove to the federal government that the people who are assigned for this high generous benefit would actually meet the income qualifications. So that's probably true for Medicaid as well. We haven't discussed Medicaid, but that's just an important administrative cost to keep in mind, this shadow eligibility that would need to occur. I also wanted to mention the auto enrollment applies to this population. So there's something called default enrollment, and this is not currently done in Washington State, but it is done in other states. So duals who become Medicare eligible can be automatically placed into plans by an insurer in some states, if that's allowed. And then there's also auto and facilitated enrollment, and this occurs in all states, including Washington. And so LIS eligible individuals can be placed in a low premium Part D plans because the federal government is paying the Part D premium. So they think they want to make sure that they're not paying a really high premium for some reason. So there can be auto or facilitated enrollment into a low premium plan. And so those features of these programs, I think, present both opportunities and risks for Washington. It's possible that it could end up moving beneficiaries from a state preferred plan into a non-state preferred plan. But on the other hand, with a little bit of careful thinking, Washington State could use these mechanisms to have people auto-enrolled into the plan that they wanted the folks to go into. So that's another consideration. So I think that is my last slide on this, and we can stop or have more. Well, maybe we should just move to the summary and discussion, because we can put up, it's just one chart if you wouldn't mind advancing. Yeah, so we can have this in the background. This is my sort of, I tried to summarize the pros and cons of the various options, but would welcome other discussion right now. Any further thoughts, comments?
This is Eddie. It's a lot to take in, obviously,
Great.
but it's a great chart. It's a great chart.
Well, I love this chart, but no easy answers.
Nope.
Sometimes it's hard to understand where we're entering into a mature market and we're providing an equivalent, or we're providing more than. So it's more apples and apples versus apples and oranges. And in that, sometimes it becomes unclear.
Yes.
I totally agree with that. And that, I mean, that's something that permeates sort of the Medicare for all sort of debate, is that Medicare is actually less generous than what most envision when they talk about Medicare for all. And it can lead to a lot of kind of a lack of clarity when discussing policy options. Okay, well, Pam and Angela, I'll turn it back to you because I think we've covered everything I had to cover.
Yeah. Thank you. I didn't want to rush any discussion, but I also want to make sure we have time for to go through the decision-making process. First of all, Christine, that was amazing. Thank you. It was really good. And I feel so fortunate to have you. Before we vote, I want to note that the commission's direction to our recommendations, we don't have to reach 100% consensus. We can have different points of view about this, especially at this time in the discussion. So what we want to do is as we understand different points of view, that we kind of capture those and document them. So that will be part of what Liz is doing with us. And then if we want to hold back on something, we can do that at this point. Sometimes in some cases, we may feel like we don't have enough information. It doesn't mean we can't return to a certain topic or a certain way of looking at things at a future meeting. We're going to be going to tab 6 for looking at the slides for the Medicare votes. And then I'm so grateful that Liz Archon is here to help us facilitate us through this decision-making discussion. So Liz.
Thanks, Pam. So we've set up. Oh, can you all hear me?
Yes.
Okay, sorry. So we've set up a series of votes for you. Hopefully you've looked through the packet and kind of seen them, and we've queued them up through the conversation. I just want to reiterate what Pam said. It's not really about whether or not the commission is going to include Medicare in the universal system that they're designing. It's really about to what extent it's included in a design process right now. And if there's an option that would allow the commission to ensure parity for Washington's Medicare recipients while not necessarily be included at the core. So Roger, I think it's almost the flip of what you were saying, where you were talking about, what are you, if you're trying to change the benefit, if you're trying to take 5 or 6, I think it was 6, and raise the benefit level up, what are you actually aligning to? I think the question on the table really is, if we include Medicare in the beginning right here, there's a lot of constraints right now. Is what is the best pathway right now for the commission to try to move forward in its design process? And that's what this series of votes is about. And again, just because there's a vote now, it's not binding forever. So if the state, for example, if the commission goes ahead and designs the program and includes other different types of programs as we're designing it, and figures we're going to fill in the gap for Medicare right now, in a few years, after the state has shown that the system works well, they can go back to the federal government and say, we're actually doing a great job in our state, and we know how to do this, and give us this waiver. There's a lot more reason for them to consider doing it. So I just want to try to set that stage as we're sort of thinking through the different things here. And if there's something that's not included in a vote, this is really up to you about what makes the most sense for the commission to think about as they try to move forward. So I hope that's helpful. And I'm going to hand it over to you, Pam, to actually facilitate the votes themselves.
Okay. Okay, the first one to motion to recommend or not recommend is an act of Congress or comprehensive waiver at this time. And I got I think that the best thing might be to go kind of around the room and see where people are. And so I'm gonna, and Roger, you're at the top of my Hollywood squares here. So where are you on this one? I think you're on mute.
I'll get this, yeah. I would propose or recommend, I need to be careful how I'm saying this, that we not actively pursue seeking a Medicaid waiver or congressional action at this time. But in saying that, it's not to suggest that Medicare should not be part of the comprehensive system we're talking about. It's rather the timing and resources that we devote to this issue, that is the Medicare issue at this time. I guess in my view, I think we can proceed, or the commission can proceed to develop its notion of a, you know, what it means for the state of Washington. And then turn to then say, okay, we now want to incorporate Medicare into this, but we know what we want to bring Medicare into. So I think it would be better spent for the commission to devote on the development of the new system, recognizing that eventually Medicare will be part of it. Two other comments, if I might. One is that if there remain questions, and I can see why there is, about what options are available through the various forms of the waivers, I would offer, and there may be some resources to do that, that the commission consider, if you will, contracting with a nationally recognized law firm that deals actively with CMS to clarify the existing waiver options that may be. I think the folks in California and the work they did was very good at that, but I guess another cut at that would be useful. And as part of that, developing, you know, and understanding those pathways is to have consultations on behalf of the state with CMI. I can use a firm as an example. I'm not trying to sell them, but we in the past have done that with a firm called Covington and Burling. So there are firms that can provide and do that analysis for us. So if there are any questions that remain on that, I would offer that we give that some consideration. And the third one would be is that the commission at such time as when Oregon's new Universal Health Care Plan Governance Board, it's a long one, becomes operational, and supposedly there's enabling legislation going forward this session to make that so, that we being the Universal Health Commission actively partner with Oregon on exploring these options. I think it can be done so in a way that doesn't drain valuable resources away from the commissions more immediately, but that partnership we could leverage. So that would be a sort of a third recommendation around that option number one.
Okay, thanks, Roger. I think if I want to capture the essence of what you said, which is you support number one, but not at this time. It's something that the commission should look at in the future.
Yes.
I wanted to just are there others who agree with that point of view?
Yeah, I would agree with that.
I do as well.
Anyone else?
Yeah, I do too. The federal process will move, but at its own pace. So we don't want to be held up for that. And I think that's what Roger's trying to get at.
Right. Anyone else?
I think that's sort of where I am too. I mean, I definitely don't think at this time. It may be something to revisit later.
Okay. Did I get to everyone? Okay, and that's where I am too. And the reason when you said that, Roger, I was like, yeah, that's what I think. So I was wondering what the rest of the group is. So does anyone want to add anything to number 1?
I do.
No, I'm going to ask you not to, if that's okay,
All right.
because we have 5 more. If you can say, but that doesn't mean I won't come back to you if we have time. Okay. Let's go on to number 2, which is demonstration waivers such as via 1115A at this time. And Christine, you're at the top of my screen this time.
You know, I wouldn't support this one with the sort of idea of this is going to be how we implement universal healthcare, the universal healthcare plan for the Medicare beneficiaries. I think it maybe is something Washington State should consider for other reasons, you know, to reduce cost or to sort of be a complement to the universal healthcare plan. But I think if the idea is just to try to roll Medicare beneficiaries into the UHC, this is unlikely to work exactly as intended for that purpose.
Are there other points of view?
I would agree with Christine's assessment, except in the context when we talk about payment models, it might be an option to apply for a Medicare waiver to supplement the goals of the universal healthcare initiative.
In terms of payment model?
Yes.
Yeah, that makes sense. Others? Eddie, Kai, Roger?
I concur with the recommendation. If I could add one real quick other thing, we've talked a little bit about, you know, looking at payment models. There is going to be some work that's coming year through the Office of the Insurance Commissioner and our Attorney General to look at, if you will, options that are occurring in the state of Washington, consolidation in a variety of efforts. One of those, interesting enough, includes the exploration of global budgeting. And I'm reading that, if you will.
I'm going to pause you until we get through the Medicare decisions. I'm excited about payment models too, though. Okay.
I think that the demonstration waiver sounds most interesting in that you have to go through the process of how to fulfill it. But I concur with, I think, everybody else on that.
Yeah. Okay. Liz, does that work for you?
Yes, I think what I put, I flagged that people like the idea of the Medicaid waiver for addressing cost containment almost as a companion to the universal design.
Yeah. The only thing I would add on demonstration waivers is my experience is they are a huge amount of work. And so you go into them really deciding that's where you're going to invest resources because you'll have a big return. Okay, 3, a state-operated Medicare Advantage and Part D plan as the only option for Washington Medicare beneficiaries. Eddie.
Why couldn't I get 4?
I'm sorry. It's all about where you land on the screen.
Yeah, it's just a hard to envision how the state would legally do that. So I think you could start with number 4 and learn a lot more. Then you could go through the process of trying to believe you could pull off number 3. So yeah, I think that's something that's further down the road. So it's a good idea, but I don't think you're going to be able to show it right from the start.
This is Robert. Yeah, that was my assessment as well. So I concur with Eddie.
Christine, where are you?
I concur.
Roger?
I concur. Added with the fact is, in my view, there is no freedom of choice vehicles available for this to limit access to a single payer plan. So I concur, and I don't think there's a waiver pathway to achieve this at this time.
I also concur, and I think taking choices away from people prematurely, even for their own good, can be dangerous. Okay.
Sorry. I think with 3 and 4, just to reiterate my earlier point, my concern is really with just administrative burden, right?
Mhm.
It's effectively probably more than doubling the work, right? Just to design in parallel the UHC plan and also add on a Medicare Advantage plan.
Okay. Thank you. Okay, Liz, I'm going to move on unless you are catching something I'm missing. 4, state operated MAPD plan that would compete with private MA plans and traditional Medicare. And Kai, I'm going to ask you to weigh in first.
Okay, yeah. So I won't repeat what I just said, which applies to 4 as well. But I think maybe I guess the 2 points. One is the advantage is that it allows individuals to have choice, which is good. But I think that the question about that earlier discussion about like benefits and benefits riches relative to other MA plans, like if you were to go after this, would it just be by design, by competition, just another MA plan that has benefit generosity that matches other MA plans and is not at parity with UHC, or would the state be pitching a plan where the premiums do not fully cover? Is that even feasible, like to cover not the full cost of administering the plan, in which case then you could have benefits that are richer, which would be closer to a UHC, coverage. So having said that, I personally would not recommend 4.
Any others?
I like Kai's questions, and I also like that Roger brought up there's well over 100 plans that you're competing with.
Mhm.
But I think you could learn a lot and answer some of those questions. And yeah, that's one of those things where you want to learn on a small scale to uncover and find those opportunities. This is kind of that brick and mortars approach where it's starting from the ground and throwing you out into a really mature market, and a lot could be learned from that.
Yeah. Anyone else want to weigh in on 4?
I don't think we should take it off the table. I think it's something that should be kind of thought through a little bit more. Maybe it could work in combination with 6. Maybe what to Roger's suggestion, maybe having a law firm look into what exactly is possible with this option might be worthwhile. But I don't know that I'm ready to say hard no, but it does seem to have a lot of hurdles. I will say that.
Right, we keep on the table.
My sentiment is similar to Christine's.
Okay, thank you, Bob. Was there anything else to add?
Yes,
Roger?
I have a medium hard no, I guess for a couple reasons. One is we'd be entering a mature market, which to me says that the state itself would have to administer its own plan. It would have to operate internally a fee-for-service system that was its own plan. So we don't have that capacity, in my opinion, at this time. Secondly, I would be concerned that it could place the state, in theory, at risk, because in the end of the day, we're going to get states get a per cap for an individual, and the state itself could be exposed to downside risk. And in my view, I don't believe the legislature, and I will understand their apprehension about that, will be willing to want to entertain that sort of risk at this juncture. So I guess mine is a fairly hard no at this time.
Okay, we have kind of keep on the table to hard no, I think. And I think it makes sense on this one because there's lots of possibilities and lots of risks on this one as well. Anyone else? I think we kind of captured everyone's comments. Okay, let's go on to the next. a state-operated Medicare supplemental insurance Medigap plan. I think, Bob, I think you're the one, you get to jump in first on this.
Well, so it's sort of out of my expertise, but I'm a fan of incrementalism, and it seems like either 6 or 5 would be, because they're most politically feasible, good places to start. So anyway, I would be supportive of option 5 or 6. That's about all I can really volunteer at this point on those.
Okay.
On 5, that still is also entering a very mature market, and it's a pure insurance play.
Others?
You know, comparing 5 and 6, I felt 5 seemed so limiting in that it is restricted to traditional Medicare. It doesn't cover, you know, additional supplemental benefits like vision and dental. It has these funny constraints around A, B, C, D to F or whatever. Okay. To me, 6 is a lot. Like, I kind of lukewarm on 5 and would prefer 6.
Yeah, I like how you like them.
Yeah, I think 5, you're just crunching some numbers and you're competing in a very mature market, and you're going to have to play with what's currently there, versus 6 where you're changing it. So you have some advantage.
Yeah, I like 5 and 6 paired with like 1 or 2 in a stepwise fashion.
Yeah.
Right, like 5 and 6 being positioned in the sort of like earlier stream of work. 5 has the advantage of just standardized benefits, right? That saves a lot of work. But also, like, I think to Christine's earlier comment about you know, for fee for service only, there could be also like a disadvantage of, you know, just sort of probably pushback from MA plans, right? Because you're basically enriching the effective richness of fee for service.
And I get a sense, well, so Part A, Part B versus Part C percentage coverage in the United States versus in Washington. And then in Washington, you know, our managed care very high, you know, 90%. If the state, if you go back 10 years, it probably was 60-40 or something, maybe 40-60. But if you transition to more of a fee for service structure and you take on some risk there, it does change things. It's an interesting thought.
Roger, did you have something?
Yes, I'm opposed to this recommendation at this time. I should say that, but
Number 5.
A 5, but I would recommend or suggest somewhere that the commission continue to endorse the existing work of our state legislature to expand the Medicare savings program. I see that as, we're talking about the cost sharing side, I see that as a vehicle to, you know, have meaningful impact for lower income individuals. We can draw federal dollars to assist with that. It's a program that's existing today. It's consistent with the direction that our own state legislature has done. So mine would be is to oppose option number 5, certainly at this time, and recommend the commission continue to endorse the work of the legislature to expand the Medicare savings program.
Yeah.
And sorry.
Oh, go ahead.
And then the other one, I think, when Christine was giving her cons against 6, she had some interesting situations that could arise, and, you know, kind of, you'd have to go down that rabbit hole a little bit more, where they don't sign up for a plan, and then basically the state becomes the payer of last resort or something.
Mm-hmm.
So yeah, there were some technical nuances there that were interesting.
Yeah. I like how 5 and, you know, it's the kind of the pulling together of some of these, because they do potentially interlink as we look at implementation. And I like others, I don't like 5, but that's maybe a bias against Medigap plans, and kind of against the very idea of trying to do something comprehensive that's not pieced together. But I like the idea of thinking of how could 1 work with 6, in the sense that is 6 could be a stopgap, or 6 could be, and somehow you do that first, or you go after 1, and if it's not going to be successful, then you could come back to 6, or maybe a Medicare Advantage plan. That's another way of looking at it.
And I think, there may be there may be more, if for now we're tabling, 1 and 2 at this time, we can spend more time talking about some of these other options, additional questions that have come up as we're trying to do more design work. It's just about whether or not Medicare is the benefit plan that's at the center that we're designing around. So I think what you were saying, Roger, about Medicare savings plans, do we need to learn more about that? Like, there are other things that could potentially be brought to the table as we're trying to figure out how to address Medicare. It's just what we're going to prioritize now. So we want to prioritize spending some time, if the commission wants to spend some time, or FTAC wants to spend some time understanding more about number 6 and how it could work, or number 5 and how it could work, that's up to you. It's really more of a priority exercise at this point.
Mm-hmm. Do we have enough, Liz, to be useful to the commission?
I think so, because I think you're clearly saying to them that at this point, right now, pursuing 1 and 2 doesn't seem like the best course of action. Instead, we should look at options 5 and 6, potentially, to make sure that there's parity for Medicare recipients. We should be exploring that, but that we should continue figuring out what different programs come into the program. Right now, Medicare will be addressed, parity will be addressed, but it won't be at the center of how we're designing.
Mm-hmm.
Could I challenge that a little bit? And I'll try to be brief. Sure. I'm sorry, Pam, but I guess I would say around number 1, repeat again, I think it's the North Star. So we're not taking it off the table permanently.
Right.
But I'll just repeat again, until we design a system, we don't know what to do with Medicare.
Exactly.
Okay. So that's my own opinion, where our commission ought to be focusing. Right. I would say, if there are questions about this complex area of, what options are available today, to suggest that there are others, we can again get a second opinion from, I keep using Covington and Burlington, but there's ones like that, to have them go through another, analysis, including bringing in the politics of that, which they will understand, being, in DC, and that I think would be useful, because it is going to help us in the long run with a pathway for Medicare eventually. And the third piece, again, is to encourage our commission, this all being said, to link with Oregon, because they're ahead of us on this. We want to partner with them and use their resources, and maybe we can help them in this, to move down this direction of how we're bringing in Medicare. So I guess I'm trying to advocate for those nuances to be in that discussion, Liz, rather than just put it aside for now.
Okay.
I think the intent is to capture those nuances and those additional suggestions to share. And Liz, I'd like to kind of bring it back also to this group, just feel it, maybe check in with people. Did we capture it? Is this what you said? I think we
can draft something. We'll draft something up with Pam and the staff and circle it back to you before it gets presented to the commission in June. So
one last thing, I promise I'll shut up. So I would appreciate that. And again, with respect to 5 and 6, that how those get drafted is in those, that which gets back to the commissions, to say there are some existing pathways now to move towards accomplishing what 5 and 6 are trying to accomplish more globally at some point in time. And we need to keep those on the table.
We will. That's so I'm going to bring us to a close. This has been great. I'm very impressed that we were able to get through so much complicated stuff. And then I think that what we are going to do now is go back to Liz for kind of bring us
Yeah, I'm going to just quickly update all of you on the last commission meeting and make a request for all of you and then hand it over to Bob. So as you all know, the UHC is responsible for making recommendations on transitional solutions and as part of the move to a universal system. We interviewed commission members earlier this year, and they asked all of you to offer some thoughts and ideas about what some solutions might be. And we talked about that at our last meeting together, and we had prepared to bring that to the commission for their April meeting. Unfortunately, they didn't have time to talk about it then, and they're going to be talking about it at the June meeting. So I just wanted to update you on all of that and let you know that once they have their discussion, we'll make sure you're aware of what they're putting forward at this time. We anticipate that over the course of the time together, there will be other ideas that emerge. Although they did not get to the conversation about transitional solutions, there was a preliminary conversation about ERISA plans, similar to and mainly about trying to queue up some of the questions that they are wondering about, similar to the conversation that we just had about Medicare. And so I'm not going to read through all these, but you can see on the screen some of the questions that they're pondering, and they're going to be talking about ERISA again, kind of refining their questions at their June meeting. And our ask of you is, if you have the expertise and are interested in helping walk through a conversation similar to what Christine did today with Medicare, we'd ask you to reach out to Angela about helping to pull that together, and that would happen in July. So that's that. And related to the transitional solutions, while we don't have a specific ask right now, many of the ideas that you all put forward were related to cost containment. And I think we heard earlier from a couple of folks in our discussion about Medicare that cost containment is going to come up no matter what the system eventually looks like. I think there were a couple comments during public comment as well. And so we thought it was a really great opportunity to begin starting to have those conversations with all of you. And so we've asked Bob to provide a brief introduction about some of the various cost containment strategies that are out there, because we know that no matter what the design is, it's something that you all are going to have to grapple with. So I'm going to hand it over to Bob. And again, anticipate that we'll be talking about this throughout the course of our work together.
Great, thanks very much. So I'll try to get through this pretty quickly because I see we only have like 8 minutes.
We can potentially stay a little bit longer.
Okay, all right. Well, I'll still just do kind of maybe go off script a little bit and do a more abbreviated overview. Why don't we jump to the first slide? So I had conversations with Pam in particular and about whether the group would be interested in different models. I wrote a paper with Katie Guttickson at UC Hastings School of Law about these different models. And just before jumping into them, I just also make mention of the fact that the Congressional Budget Office and other healthcare policy experts have sort of identified rate-setting methodologies as the most effective way of controlling cost growth, as opposed to transparency or other pro-competitive initiatives. Those aren't harmful necessarily, but they just have not empirically been substantiated as controlling cost growth or expenditure growth. So maybe move to the first model, which is, we're not going to talk about public option because Washington has a public option, but the first model to discuss will be just cost growth benchmarks. So go to the next slide. And so again, I won't spend very much time on this because Washington has a cost growth benchmark, setting an overall target for expenditure growth on an all-payer basis. It's typically matched to what people in a state can afford, so they look at gross domestic product rates of growth, it has and generally envisions some type of authority that the state could exercise on individual hospitals or providers or health systems that are not compliant with that growth target. Go to the next slide. So it has several advantages. I mean, it just generally more from the standpoint of education and providing transparency. I think Massachusetts, which is the first state to implement this, showed that it could have a naming and shaming effect, which maybe have a temporary impact on cost growth over time. I think the biggest value add is the fact that it starts to identify cost drivers and a process of collecting data and transparency that could support other policy options. The big problem with it is more in enforcement. Massachusetts has implemented this for almost 10 years now. Back in 2012, they started, and they're still struggling with how to rein in individual bad actors from a regulatory standpoint. I think a lot of these attempts could be challenged legally by providers. So anyway, there's some issues with regard to enforcement. And so my read is it's unlikely to be the most effective approach over the long term, and states need to look at other more specific rate models. Let me go to the next slide. I don't know, the slide is blank. Maybe try the next one.
I'm going to stop sharing for just a moment, Bob.
Yeah. I can just go on my own. I have the slides here and just talk.
Okay, give me just one more minute. If you know what it was, Bob, I'm going to work on pulling the slides.
Yeah, well,
back
so
up
that
if you
the
wanna.
next slide had to do with the next model, which was affordability standards. This would be modeled off of Rhode Island. The Office of the Healthcare Insurance Commissioner has the authority to review contracts, both small group, large group, and individual, and make sure that the negotiated increases between insurers and providers, this is commercial now, it deals only with commercial insurance, meet a certain limit that's already been established. The limit is the Consumer Price Index, a modified version of that. And the insurer can approve or deny those contracts, which has an impact on giving insurers in the state more leverage to negotiate lower rates of growth with their accounts. And so it has had some success. It's been reviewed, not rigorously, but there was an analysis that was performed that showed that Rhode Island, this initiative did have an impact on hospital growth rates. Now it also doesn't affect volume issues. So if volume's growing rapidly, this really just deals more with prices. There was also some evidence to show that there's some leakage, that while hospital prices have not increased as rapidly as in the rest of the country, other provider prices have increased. So there's no control over other providers. It's directed at just hospital. Go to the next slide. So again, it has some demonstrated success. It's a low intensity rate regulatory approach because it sets overall limits, doesn't try to control individual prices. It really has kind of a lower level of regulatory oversight and intensity required. So this is something that states could implement, and I think Washington could be well positioned to implement something like this. Go to the next slide. Next model is out-of-network price caps. This is an idea I think that I first originated back in 2013, where right now, insurers and hospitals, when they negotiate, a hospital can threaten to go out of network and then bill very, very high charge amounts for the remaining beneficiaries that use that hospital. And that leverage effect really does affect contract negotiations for in-network rates. And so this proposal would kind of reverse that circumstance, where if you set a cap on out-of-network prices, then the insurer could probably negotiate prices that are at or very close to that cap on out-of-network, because the insurer then would have the option to say, fine, if you don't accept my proposal for these in-network rates, go out of network and I'll pay you at the cap. So it kind of deals with that dynamic. Go to the next slide. So as I said, it would allow insurers some additional leverage to negotiate lower in-network prices. A prototype for this is the Medicare Advantage market, where there is a statutory cap on out-of-network. And probably as a result of that, Medicare Advantage prices are the negotiated prices that the Medicare Advantage plans can get are very close to traditional Medicare. So it has that limiting effect and provides more leverage to the insurer. You also see other examples of this dynamic in state surprise billing legislation. California is an example. RAND and others have quantified a fairly substantial savings that could result on in-network care and negotiated prices if you had out-of-network price caps. It's also a lower intensity approach because you're only regulating a small sector of the market, just the out-of-network sector. So maybe go to the next slide. The third model are hospital global budgets. I have a lot of experience with this. We started global budgets in Maryland for rural facilities. After I left, the state expanded, as you know, to global budgets for all hospitals. Again, it's, I would say, a moderately intensive regulatory approach because it regulates the aggregated budget amount for the hospital. It's not regulating individual service prices, which can be quite challenging from a data collection and a compliance and overall regulatory oversight standpoint. It can be implemented on an all-payer basis, requiring a Medicare waiver so it would be, part of that option 2 add-on that we discussed earlier. Budgets can be either 100% fixed, as they've done in Europe and Canada with some issues and problems, and they've also done that in Maryland, or a proposal that I've advanced, which is a more flexible approach where hospitals are paid just based on their marginal costs, up or down with volume changes. You could also supplement the model by adding in a pay-for-performance program to reward improved quality. So why don't we go to the next slide, try to get through this. There are 3 areas that have successfully implemented. The one model, which is not really thought of much because it was a long time ago, was in Rochester, New York, and also in the Finger Lakes, where they negotiated or set up basically an all-payer rate setting global budget system for hospitals in the Rochester region, also the Finger Lakes. It was more of a flexible budget where they were paying on the basis of marginal cost. Maryland is the second model. It has had some success, but I think is too rigid because it sets fixed global budgets. And my own bias is that sets too strong a set of incentives to reduce care. It can result in shifting of care to other non-hospital providers and also stinting on care, increasing wait times for emergency elective procedures. That was the experience in Europe when they implemented global budgets there. Pennsylvania is, again, another rural model, and it's focused on the rural hospitals to try to shore up their financial stability. Go to the next slide. Now, fifth proposal is one that was advanced by some Harvard economists, Mike Chernew, Lee Moore Daphne. We talked about setting price caps, but very, very high price caps to cut off the most egregiously high market power and provider pricing. But they also recommended a state would impose limits on price growth, sort of similar to the Rhode Island model. It would be directed at commercial prices. I think that's the component of the proposal that has the most potential impact. But I categorize this as a more intensive regulatory approach because it would be setting price caps on all services, requiring significant data collection and also compliance and regulatory authority for an agency regulating this. And similarly for the price growth, while that could be most effective, it would require pretty significant legislative authority for a state. Not beyond the realm of possibility, definitely doable, but more complex. So I kind of discard this now as something that states would want to take on. Go to the next slide. So again, the benefits are you truncate very high prices. You could have some impact on restraining expenditures by having this limit on price growth. You could tier the limits to give providers that have very low prices currently a higher potential update annually, and the highest provider prices could be getting the lowest update. So there's some nuance to the way this could be implemented. But I think it's a very intensive model right now. It's something that most states probably don't have the appetite or capability to take on. And then the last is population-based payment. I won't spend a lot of time on this. There are not a lot of good examples. It really requires more overall regulatory approach. Vermont did try to approach something like this with their all-payer ACO model, but ACOs are just virtual organizations. They're not really highly integrated. You really need a set of mini Kaiser Permanentes that are competing against each other. There is a model internationally in Israel that has such a model where they have 4 health plans that compete against each other. They're integrated financially and clinically. They own their own providers. There's a lot of risk sharing and budgets that are set up. It's a fairly effective system, but as I said, it requires basically a large amount of regulatory oversight. I think it's similar to Alan Enthoven's managed competition plan idea, which was advanced back in the 80s and 90s. So the next slide, it just kind of just talks about some of the examples. The Kaiser in the Israeli plan. I think it has the most potential for controlling costs and would integrate very well with the universal health care system, but it's probably the most challenging to pull off. Again, I tried to present these in the order of like lower intensity to higher intensity to the regulatory effort. One caveat to be aware of is the fact that some of the more complex regulatory systems tend to be prone to things like regulatory failure and regulatory capture, and I can talk more about that. But obviously you've got to start somewhere. I would advocate trying to set up a model like either the Rhode Island model, reviewing rate increases of insurers and providers, what they negotiate. Rhode Island may be a rarefied example because it's kind of a unique state. Either that or out-of-network price caps, which is a lower intensity approach. Washington State does have an interest, and I've talked to people in the Office of the Department of Insurance and also some consumer advocates that are looking to try to fund some studies about the impact of out-of-network price caps. There's also been discussion about global budgets. The CMMI is soon, I think, to propose a model for states built on the Maryland experience and an all-payer approach, which require Medicare waiver to implement global budgets for states. I would advocate a more flexible approach, not the fixed global budget. But let me stop there and see if there are any questions. I know we're kind of past time. So Angela or I'll turn it back to you.
Okay.
See Roger's hand?
Yeah, Roger.
Bob, great presentation. Thank you very much. A quick question. Do you have any experience or knowledge, and I'm going to use the term selective contracting. It was an approach we used in the Medicaid program where we set price ceilings and floors and required plans to literally, come in with competitive prices. And for the several years I was involved with it, it enjoyed, in my humble opinion, a great deal of success. So I guess my question is, do you have any experience, awareness of other states that have done that, either in the Medicaid program or, for example, their public employee programs?
Well, I'm familiar with the term. The one state that I would point to that did have something similar to that was West Virginia, where they did apply for a Medicare waiver. They wanted to set up an all-payer system, but they were denied by CMS or HCFA at the time. But they set up a system regulating commercial payers where they set a floor, which is based on what the provider's reported cost levels were, and then a ceiling, and then they allowed negotiation between hospitals and insurers in that corridor. Now, that was an interesting approach. I thought it was more kind of a quasi-regulatory approach, which I would advocate in many circumstances. But it was successful. But the problem was the rate of growth that they allowed was not very tight over time. So the overall program was not that cost effective. So you really have to, you'd have to couple some type of cap program with a fairly tight rate update program to make sure it's effective. The other weakness of that approach is it doesn't do anything with regard to healthcare volumes. So you could get volume growth under that type of circumstance. And in Maryland, when we were setting very tight rate updates, the hospitals went to town on increasing their volumes. It was just remarkable. So you have to address the volume piece.
That's right. Are there other questions for Bob?
Interesting in your example, the floor, how did they determine the actual cost? Like what was, sorry, it's almost a side question, really.
Yeah, I don't know the exact methodology, but like Maryland, I think West Virginia required the hospitals to file uniform cost reporting so that and that was audited so that they have some data to be able to do it. Now you could use Medicare cost reports, but I don't think Medicare cost reports are that reliable. But you need some sort of internal uniform reporting system to be able to determine hospital costs, have it audited, and Maryland has such a system. Other rate setting systems had that as well.
I had a question as well. Thanks for the presentation. So related to price caps, is there a reason why you couldn't reduce the administrative burden of price caps by just implementing caps in a subset of services? For instance, like in Washington State, you have the operator claims data set. And so you could look at the, so you have prices and you have services, and you could look at the sort of like distribution of prices and the variances around those prices for each individual service and just cap the ones where the variance is substantially high and where the potential budget impact because of volume and price are going to be substantial. Would that help you sort of tap down on the administrative burden of setting price caps for every service?
Possibly. I just think you're going to have a sense as to what's going on uniformly. And if you're just monitoring subsectors, then there could be leakage to other sectors that aren't being monitored. I just think when you're doing that type of approach, you're going to have to collect a lot of data, and also on a very frequent basis, and then monitor it and have pretty significant legislative authority. It's not that much different than what Maryland set up originally, or some of the all-payer states. It's not beyond the realm of possibility. I think it's completely feasible, but it's a more intense regulatory approach and more detailed, and then you get into complexity and potential for regulatory failure. Whereas global budgets, the locus of regulatory control is at the aggregate budget level. Now there could be, should be analyses to look at what individual prices are doing, just out of equity and so on and so forth. But it's easier when you're looking at an N of 1 as opposed to an N of 20 for 30,000 to monitor and regulate.
Yeah. We're over about 11 minutes or so. And actually, I feel like people are still going strong. So I think that's, but I want to be respectful of kind of our time limits. Bob, I really appreciate this. And we obviously want you to come back to us on this topic. And I think take an even deeper dive, especially given the kind of questions I'm hearing from folks.
Yeah, it'd be good if people had 1 or 2 or 3 of these models that you want to do a deeper dive on, and then I could easily do that.
Yeah, that would be great.
Yeah, I would recommend out-of-network price caps and global budgets as the 2 that I think are most feasible. And I know there's some expression of interest in the state of Washington.
Yeah, that would be really great. Really appreciate the time. Really appreciate the committee members actually really diving in and helping us today, Christine and Bob. And everyone really for your participation. It's a really good meeting. Next time is July 13th, and we'll be following up, especially with the kind of the analysis of our Medicare votes to make sure everybody has a chance to look at those. And if you have questions or issues that come up in the meantime, please reach out. We also will be pulling together kind of an ERISA discussion as well. We may be pulling some of them as well. So thank you very much. Really enjoyed the meeting and look forward to seeing you in July.